Morning. This meeting's called to order.
Your mic's not on.
Oh,
We're off to a good start. All right, good morning. Meeting's called to order. Welcome to the last PEB board meeting of the season. Our meetings will continue to be hybrid. Healthcare Authority staff will be on site. Board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information about how attendees can turn on closed captioning. Let's go ahead and do introductions. We will start with Michaela.
Hello, good morning, present.
Welcome. Monica.
Present.
Tom.
I'm here.
Elliot.
Present.
Harry.
Present in the room.
Kurt.
Present.
And John.
Present on time.
Outstanding. I like that clarification. And then Michael Tunick from the AGO.
Good morning, Chair McDermott.
And I'm Lou McDermott, Deputy Director of HCA, and I'll be filling in for Sue as the chair today. With the board members attending both in person and virtually, it'd be helpful for board members to hold their questions until each presentation is done or when the presenter pauses and asks if there are questions. Board members attending virtually will also be watching in case you use your Zoom hand to indicate that you have a question. There are going to be several resolutions scheduled for action today, so the public will have an opportunity to provide comments on those specific resolutions during normal procedure before the board votes. Public will also be able to provide general comments at the end of the meeting during the public comment period. As a reminder, if the public has questions during staff presentations, the presenter's contact information is included at the end of their presentation. You're welcome to email them during the meeting to capture your question for a response after the meeting. Dave, what are we doing today?
Good morning, Chair McDermott, members of the board. It seems like much longer than 7 days ago than we were all together. The weeks are very long right now. But we have Tanya coming back with a little bit of refreshed updates on some of the rates and premiums for our employee and non-Medicare population, and we'll ask you to take action on resolutions today. As a reminder, as it sits right now, the only plans that exist in the PEB program are the Medicare plans, because as a reminder, there are no plans for 2024 until the board affirmatively votes to authorize a plan. So that's why it's such an important meeting today, to be able to set the stage for open enrollment. As always, Ellen's here with a little bit of updates on how we engage with our Medicare population and answering some questions and talking about how we're leaning forward into open enrollment. And then Alyssa will be with us to really talk about that pivot as the agency moves from the end of board season, the culmination of the rate development process, and transitioning into the more operational roles related to open enrollment. And then you'll remember last week we thought we were going to have a Smart Health presentation about the change to WebMD in 2024, but we moved that to today, and so Kristen is here to finally give that presentation, and then we will be wrapped up. As a reminder, bathrooms are down the hall to the right. If you see elevators, turn left, and if we have an emergency, we go out to the left back into the visitor parking lot. And with that, I will turn it back to you, Chair McDermott.
Any questions for Dave? All right, seeing none. First up, the approval of the July 12th meeting minutes. They're behind tab number 3. Are there any comments from the board? Seeing none, do I have a motion to approve the minutes as written?
Moved.
Second.
All in favor, say aye.
Aye.
Any opposed?
Aye.
Hearing none, July 12th, 2023 minutes are approved as written. Dave, program updates?
Good morning again, everyone. I just had a couple of general updates as we're rounding out the board season. There were 3 things that I wanted to highlight, maybe 4 actually as I'm thinking about it. General things about the program that were being worked on. I wanted to do a quick refresh on where we are on the Benefits 24/7 launch, which is the open enrollment system that we've been building for a while. I think when I last left off with the board, we had announced that we were not going live on June 12th. We were identifying a new launch date, and I may have even at a prior board meeting indicated that we were looking at January of 2024. If not, I'm saying that now. We had considered and we're trying to see if we could leapfrog and get completed in the month of August. But there are a variety of different factors between the PEB and SEB programs because this is a joint IT interface for open enrollment. It's a bigger change as we've gone through this board season for the PEB program, moving from complete reliance on paper to the ability for people who want to do things online to be able to do things online. For the SEB program, it has a little bit more enhancements from SEB My Account than they have today. But the short story is, as we look at the months of August and September, there's about a 10 to 15% turnover in the K-12 workforce every school year. And so we didn't want to bifurcate the responsibilities of our benefits administrators in the SEB program at school districts from having to help everybody understand a new system while doing all the important eligibility determinations on thousands of new school employees. As we get into October and November, we were concerned, especially as we were seeing where rates were, that there might be much more activity from all of our populations, both PEB non-Medicare, PEB employee, PEB Medicare, and school employees for open enrollment. So we didn't want people to have to navigate a new system while also focusing on their plans. We want people to be really focused on looking at their plans, understanding what plan is best for them, and making that choice, and not having any concern or barrier about navigating a new system. We're not going to do a transition in December while we're working on all the cleanup from open enrollment and doing the eligibility file transfers. So that led us to January. I just want to say, when it comes to IT projects, we're not looking for, shuttle launch perfect conditions, but there are circumstances like I've just described that it's better to avoid for the reasons I've stated. So for Benefits 24/7, I anticipate when we come back at the board retreat that we will be talking about how that system went live. The second update that I have is really about two legislative reports that we're working on. The first one that I'll highlight is the Uniform Medical Plan Third-Party Administrator Report. So this is a report that is describing, the legislature wants the agency to describe what it would look like and what the kind of pros and cons and financial impacts would be if there were parts of, or some or all parts of the current services that are contracted out to regents for the Uniform Medical Plan were brought back in-house to the Healthcare Authority. So before 2011, the Healthcare Authority did things like provider contracting and a variety of other admin functions that are now part of that contract with regents. And so that report was trying to get ahead of the contract that we have with regents. The initial term goes through the end of this decade. It can be extended into the mid-2030s, if you can believe it. But they wanted us to do this analysis now because, as Shauna has highlighted, our UMPTPA contract took 5 years from conception to culmination and implementation. And so if the state wanted to pivot in a different direction for 2030, that conversation is germane pretty darn soon for the legislature. So we're working on that report. We're turning it in December 1st, and then afterwards it will be published on the HCA website, and we'll go over it at the board retreat. I'll go over the second report and then ask for any questions about these. The second report that we're working on is it's about the retiree engagement and the Medicare portfolio and options related to the Uniform Medical Plan Classic. That report is also due December 1st. So part of that report is describing the findings and lessons learned related to the listening sessions that were held earlier this year, and then also talking about other options within the Medicare portfolio. One of those options that I'll highlight, because I just want to keep this on people's radar, it's come up in listening sessions, it came up as part of the 50-state survey, it came up in public comment, is this idea about possibly doing something different with the formulary or drug coverage within the Uniform Medical Plan Classic. I want to reaffirm something I said last meeting, that there is no decision made. At the same time, if you hear or understand or stakeholders are engaged with the agency on work related to that idea, we have to keep moving forward and analyzing that idea. To have even a possibility of it being able to be implemented in 2025. So if you hear that I want board members to be very clear, there's no decision that's been made, but we're going to do what we need to do to keep that idea viable for the earliest possible implementation date, if it's something that everyone wants to exercise. So that will be a subset of the legislative report. That report is, I think I said, is due December 1st, and we will also publish it on the website and bring it back and discuss it at the board retreat in 2024. So I'm going to pause about those two reports, UMP-TPA report and the retiree engagement and Medicare portfolio UMP options report. Elliot, you have a question?
Yes, as a representative of RPEC, the retired employees, I really appreciate your making these reports to the legislature available to members of PEB and to the public. Thank you.
Yep. We don't publish every report on HCA's website because we have about 60 to 70 that are due every year. But historically, most of the PEB and SEB ones, we don't have as large a percentage of the agency's reports as the Medicaid program, and we usually do publish them, but we will also include the full report in the board materials when we go over them, as we do a summary of them as well. And I'll ask Jessica and Mackenzie to help me remember, when we publish those reports, we'll try to send something out at the beginning of December to the board so that you know that it's available, rather than waiting until the retreat. Those are the updates that I had that were general program updates.
Other questions or comments for Dave? All right, I do recall that procurement, the UMP, TPL, RFP. We, inside the house, we called it Fred. It was just easier, felt good. Didn't stand for anything. Next up, Tanya Dool, ERB Finance Manager in the Financial Services Division, is going to join us to present for the board the 2024 non-Medicare premium resolutions introduced at our last meeting. Welcome, Tanya. After each resolution, I'm going to ask for a motion to adopt and a second, invite public comment on the resolution, ask for board discussion, and we will ask for public comment specific to each resolution one at a time. Please make sure to raise your hand to give comments on the resolution related to the plan that your comments are about. So comments on KP should be on that resolution. Comments on UMP should be on that one. And materials behind tab number 4. Hello.
Good morning.
Welcome back.
Thank you. Good morning, Chair McDermott, members of the board. For the record, my name is Tanya Dool, and I am here today to bring the non-Medicare premium resolutions. Next slide, please. So just a little follow-up. This was only last week, so we haven't forgotten too much yet. There's been a lot of rounds of procurement, and last week seems like it was quite a while ago, but it was not. So last week at the board meeting, when I presented the employee premiums and the non-Medicare retiree premiums, the board did ask for an additional round of rates from the carriers. And we did receive updated rates from Kaiser Northwest last Friday. So those increases are on the next slides, and I will walk through those changes. I do want to also...
Tanya, you said the word increases, but you mean decreases.
I sure do. Changes, yes. So I do want to also acknowledge, so these are the changes for Kaiser Northwest. There were also some Kaiser Washington changes that were already included in the last week's presentation. So what we're going to look at today is the changes for Kaiser Northwest. What you can see here on this slide is the proposed employee premiums for 2024 for Kaiser Northwest only. These are the only sets of rates that have changed since last week. You'll see on the top the proposed rates from last week, as well as the proposed rates that are included in today's slide deck. If you do have any questions about what was presented last week, my entire slide deck is part of the appendix. So you'll see here the single subscriber employee premiums for 2023 compared to the proposed 2024, and then that percentage and dollar change for that single subscriber, comparing the rates as of last week versus the rates presented before you today that we will ask the board to take action on later. Just pause there for 1 second.
Tanya, I have a quick question.
Yeah.
Of the 2,736 members of Kaiser, that's actually the one Kaiser, there's only 340 members of Kaiser.
There's 340 subscribers.
Yeah.
So there's more members. The subscriber's the employee, and then the members would be including the dependents. Those are the total enrolled just in the high deductible health plan.
Yeah, that's the one with the 680%.
Yes,
increase.
correct. Yes.
Okay.
So it is, there is a smaller percentage of our overall enrollment within the Kaiser Northwest plans. And those are the rates that are changing this week.
Great, thank you.
You're welcome. Okay, I'm going to move on, but there's still plenty of time to interrupt and ask questions. I won't walk through all the details of each of these slides as we went through them pretty thoroughly last week, but I did want to restate each of the slides with the updated Kaiser Northwest employee premiums. So this slide, as a reminder, compares the single subscriber employee premium on the far left with the employer medical contribution, the state's contribution in that middle column, the $702, and then on the far right, we have the total bid rate. So I think I explained this last week how my brain works. I like to take the far right bid rate column minus the middle column to get the employee premium on that left. So these are with the updated Kaiser Northwest rates. Tom?
Just to make sure, Northwest Classic and Northwest CDHP, those are in Clark County and
Cowlitz.
Cowlitz. So just those two counties are the only ones we're talking about in this case. Okay, thank you.
All right. On the next slide is also a restated slide from last week. This slide, again, has the changes outlined in that box for Kaiser Northwest. This is the comparing the subscriber premium from 2023 compared to the proposed 2024, as well as a change in that single subscriber rate in terms of percentages and dollars, and then the enrollment on the far right. On the next slide, we wanted to take a moment and bring back a little bit of more of what we spoke to last week. Kurt, this is to really get to the tier factors and address some of your questions this year instead of waiting till our next year presentation. So we wanted to take a few minutes and bring that follow-up now. This slide might look familiar. I used to include this in all of my presentations historically. This is just a visual to describe the tier ratio. So you can see tier 1 is the single subscriber. Tier 2 is the subscriber and spouse or state registered domestic partner. Tier 3, we multiply by a 1.75, which is the subscriber and child or children tier. And then tier 4 is multiplied by a 2.75, and this is subscriber, spouse, state registered domestic partner, and child or children. Regardless of the number of children enrolled on the plan, it's the same premium. So on the
Tanya, I just want to highlight for everyone, you and I know this, and so does Lou, that there is no magic number when it comes to these tier ratios. These tier ratios were set by the PEB board. We'd have to go back and check exactly what year that was, but it was a very long time ago. But there is no magic number. We worked with Milliman decades ago, and we reaffirmed some of the calculus when it comes to children and using a 0.75 ratio for children as we launched the SEB program. But I just wanted to highlight that this is really about kind of looking at the risk pool and going, well, as you set up these tiers, what do you want to charge people relative to each other based on the number of dependents they have? Some programs and places and employers don't have multiple tiers. You can't enroll dependents. Some have 6 tiers, some have 10 tiers. They all have different multipliers. I just wanted to highlight that there is no magic number. And the other reason I wanted to highlight this is the tier ratios are different in the SEB program. And there are reasons why they are different. But if you were to take this slide and compare it to the SEB slide, they would literally not be the same because there is no perfect answer. So I just wanted to highlight that because I think it's a question that comes up. Do I think that one day we will ask the boards to look at this? If the programs were ever to be consolidated, there would need to be a singular tier ratio. And so something would have to change for one of the programs. It is a difference between the programs. We're not having that conversation today, but I just wanted to highlight that there is no magic number.
Thanks, Dave. So on the next slide here, this is a view of the premiums proposed for 2024 for all of the tiers. And one addition that we made to this slide is just including that tier ratio at the very top. So you can see 1.0 for the subscriber, 2.0 for the subscriber and spouse, and so on. This is, so you can do the math where you multiply the single subscriber, the 1.0 rate. If you wanted to calculate the subscriber and spouse, it's 2.0. So it's 2 times the single subscriber rate. For subscriber and children, it's 1.75 of that single subscriber rate. And for the subscriber, spouse, state registered domestic partner, and child or children tier, it's times 2.75 of that subscriber tier.
But Tanya, that percentage would just carry through.
Yes,
all the way through.
it carries
Each
through.
tier.
It carries through, and the same tier ratio applies to the employee contribution and the state's contribution. So on the next slide, we brought back, there are two slides showing the same view. This slide shows the change in subscriber tier and then the change in subscriber and spouse tier. And then the next set of slides is the other two remaining tiers. I do want to pause here. John, you asked a great question, but there is a little nuance on this slide that is different comparing plan year 2023 to 2024. And that is because with the transition to the EMC model, there was also a $10 spouse charge that was added onto two tiers. The two tiers that include spouses. We had a long-term spouse charge since, I believe, August of 1995 that had been in existence. And with that change in methodology, we also removed that $10 spouse charge. So the math isn't as quite clear this year, but moving forward it will be. So I want to bring up maybe two examples here that will help kind of draw your eyes to that removal of that $10 spouse charge. So if we want to look down the left and you see Kaiser Washington CDHP, you might notice in the subscriber tier that there is a plus $2. So from 2023 to 2024, the rate for that single subscriber is going from $24 to $26. So that's an increase of $2. But when you notice on the single or on the subscriber and spouse tier is a reduction of $6. That doesn't quite make sense with what I just explained. However, the $10 spouse charge came into account for 2023. So if you look at the 2023 columns only, the light blue, and you look at Kaiser Washington CDHP, $24 for plan year 2023, and you multiply that by 2, you get $48. As opposed to $58 that's shown on the subscriber and spouse. And that's because in plan year 2023, we had that $10 spouse charge added to that tier. So 24 times 2 plus 10 equals 58. Now, from 2024 moving forward, it's going to be the straight multiplier of times 2. So for the plan year 2024 proposed column, the darker blue, you see $26 for 24. You multiply that by 2, you get $52. So there's actually a decrease on that tier because we have removed the $10 spouse charge from the two tiers that have spouses. Now, if we want to look one row, let's look at actually UMP Select as another example.
Elliot has a question.
Yeah, Elliot?
Why was the spousal charge removed, or have you already gone over that and I forgot?
No. I was just thinking there, I saw some inquisitive looks and I was like, I'm going to try and say it a different way, Tanya, so that other people, everybody hears things differently. So back in the early 90s, before the $50 spousal surcharge, and we're very deliberate in calling the spousal surcharge that's $50 that's from the legislative operating budget is different than this $10 spouse charge that existed historically in the early 90s. So in the early 90s, we believe the PEB board set a plus $10 sort of it was like an early iteration of charging for having a dependent on your account. There's this idea that if somebody has comparable coverage elsewhere, it gives a disincentive for bringing people onto the plan if they have other comparable coverage. And so back in the 90s, the board, and I presume the agency, recommended that there be this $10 spouse charge that was added to tiers 2 and 4. It's been a longstanding part of the formula, and so that was kind of added on as part of the state index rate model, which is the old collective bargaining agreement methodology for how the employer contribution is set. When the EMC model, that flat benchmark to UMP Classic, was built for the collective bargaining process, or was collectively bargained, that methodology just simply didn't include this $10 charge. And one of the reasons that it wasn't incorporated was because if you fast forward in time, the $50 spousal surcharge was set up by the legislature. So we've constantly had this question over the years: is why are there two spousal charges? And so with this shift in methodology, it was an opportunity to just bake that change into the calculation process, and it wasn't included in the EMC model, so that it gets removed with the implementation of that EMC model.
Well, because this is so interesting to me, what is the EMC model? Yeah, I know you've been referring to it, but I don't want to. Well, I love to get in the weeds, but you'll be the best judge of how to approach this.
Elliot, the you might remember we've had a few conversations, I think starting at the retreat about it. I had those charts that had some like arrows and little boxes, colorful boxes on them. The EMC methodology is the employer medical contribution. It's the calculus for determining how much the employer will contribute to the medical premiums. With the collective bargaining that happened in the summer of 2022, starting with plan year 2024, we're moving to a straight 85% benchmark off of UMP Classic versus the methodology that's in place actually today for plan year 2023 is a weighted average methodology. That is the EMC methodology change that Dave is referring to.
Okay, just a suggestion. Sometimes I can't remember what happened back in January.
Yeah.
So for myself, at least, I'm just asking if you could refresh us.
Yeah,
just,
there is
you
a
know, as to what.
There is a slide in your appendix because I presented it last
okay.
week. So it's part of your appendix that shows that calculation.
Okay, but I'm just speaking for myself, not anyone else. I'm an oral learner, so when I hear you and Dave, it goes, now I get it.
Yeah, we can remember that for next year.
Thank you.
Yeah. So I wanted to bring up just one other example because I know this is a little confusing and not necessarily intuitive when you look at these slides here. If we look at UMP Select, you will see that the rate actually did not change from 23 to 24. So there's a $0 change for the subscriber tier. However, when you look at the subscriber and spouse or state registered domestic partner tier, you see a reduction of $10. And that is the removal of that $10 spouse charge. Going forward, starting next year, when we start comparing 24 to 25, this should not be an issue, and you'll be able to do the straight ×2 for this tier. And then the next slide is just another version, just including the 2 additional tiers. And I will not walk through the math on all of these, but the same concept would apply to that final tier on the far right, the subscriber, spouse, state registered domestic partner, and child or children tier. That same $10 math would work out on that tier. So next up is the same comparison slide, but for our non-Medicare retiree premiums. With the Kaiser rate change this week, it includes also a change for the retirees, those non-Medicare retirees who are within the PEB non-Medicare risk pool. As a reminder, these retirees pay the entire bid rate plus a small administrative fee, and here you can see how those rates changed from the rates presented last week to those this week. On the next slide, you can see the comparison for all 4 tiers here. Again, laid out all 4 tiers with the same tier ratios we just walked through, and then the change in the subscriber rate in terms of percentage and dollar on the far right. And we have outlined the Kaiser Northwest change on this slide.
Tanya, I'd like to ask a question.
Yes.
Do you know off the top of your head how many subscribers there are of the non-Medicare retirees in the CDHP plan in Northwest? I'm thinking it can't be very many. I mean, if there were only 3 or 4 actives.
Dave's consulting his map over here.
I just want to make sure, Carrie, you were asking non-Medicare subscribers in the Kaiser Northwest CDHP.
Yeah, because I presume they must be still working for somebody, or else they can't contribute to a CDHP.
There is a small number of those non-Medicare retirees total, but I believe Dave's going to get you the number here. If not, I can pull it up.
Yeah, Tanya, I think you might need to pull it up.
Okay, I anticipate someone sitting behind me might be doing that as we speak also. My great team back there.
Actually, I think I have it. Subscriber, though this is member lives. I believe it's about 75.
Okay, thanks.
I'm looking at the post-open enrollment numbers, so there might be a little bit of shift from January to July, but as of January of this year, 6 months ago, it was about 75.
Yeah, the reason I wanted to ask that was first to know, and secondly, it gives me a little bit better perspective of what level Kaiser can continue to offer these programs. thinking back to the 304,
Yeah.
what might happen in that during open enrollment. Okay, thank you.
You're
And
welcome.
I have to correct myself, it's actually 7. I multiplied that by 10. We had 7 members that were in non-Medicare Kaiser Northwest CDHP. But remember, they're being risk pooled with the active employees that are in that plan as well. That's the 340 that are on the other slide.
Yeah, I understand that,
Yeah.
but then there's an administrative cost to maintain that separate
Correct.
group.
Yep. So my apologies, I was reading the wrong column, but I looked down and it's 7.
I have a policy question. When we met with Kaiser Permanente last week in open session, they indicated that because they are both the provider and the payee, that they see things faster first before other insurance companies would see it. I'm wondering if you think going forward that we're going to see these kinds of increases from other insurance carriers in future years. And I know I'm not going to vote, but other people are going to vote on this today. And I just want to know if this is something we can look forward to in future years. The charges they were telling us they were incurring now, as opposed to other insurance carriers who are maybe a year or two behind.
Yeah, thanks, John. For the record, Megan Atkinson, I'm the agency's chief financial officer. I think you're hitting on something that sort of, is worrisome to all of us, both on the PEB programs as well as on our Medicaid programs. We clearly are in a different inflationary period, both in healthcare as well as just generally in the economy. Over the past few years than what we have been, over the past decade, right? I mean, everyone knows that. Everyone feels it, right? You feel it at the grocery store. You felt it if you've gone to buy a new car. You feel it when you fill up your car with fuel if you don't have an electric vehicle. I see it, on my kids' sports tuition. You just see it across the board, right? We definitely are in an inflationary period. We know that in the healthcare market, you have several different forces at play. So you are correct in that certain networks contract with providers or with healthcare systems and with facilities, hospitals for multi-years, right? You heard Tanya refer to it on some of our dental and our vision plans, right? We have a rate guarantee, we have a multi-year rate guarantee, et cetera. And so there will be some level of lagging as the inflationary pressures sort of work their way through the market. Definitely what we see across markets and across carriers is, we definitely see the wage impacts. And again, we know there's some goods and services inflation. I do believe we will have to work exceedingly hard to hit our purchasing targets. And our purchasing targets, sort of informally, these aren't codified in statute or legislative direction, are to keep our trends in the low to mid single digits. We have seen in some of the purchasing for 24, those creeping into the 7, 8, 9 range, right? And we definitely do not want it breaking over into double digits. I mean, some of us remember the purchasing that we had to do in the late 90s and early and mid 2000s when we were in the 11 and 13% trend areas. We don't want to be there. I believe we will have to work with our carriers, with our TPA, and with our clinical experts to really ensure that we're managing the population, implementing the right care programs, investing in the right areas, so that we can keep those trends in the acceptable range. Part of the dynamic that Kaiser has, remember, is because of their internal operational structure on their care model, their integrated care model that is quite heavy with their internal care management and integrated care management structure that is not currently in their system billable or capturable in codes. That is part of what is impacting them. definitely, I believe they are getting impacted by inflation. But there is an organizational structure there that we don't have on the UMP products, and that apparently Primera doesn't have on their products either, because they are not having those level of increases. You know, we've been monitoring the CalPERS procurement because Kaiser, obviously CalPERS has a lot of similarities. Obviously, we're a smaller state, but their board took action, I believe, yesterday on their rates. And they have Kaiser offerings, and they have offerings from a larger variety of plans of carriers than we do. And Kaiser was an outlier there as well. I think some of what we're seeing is foreshadowing our healthcare. And again, we're sort of on notice, right, on how we then stay ahead of it. I also believe, and I think this is supportable by some of the data that we have, that part of this is a Kaiser problem. So I think there's part of it is the healthcare marketplace. I think part of it is just the U.S. economy right now. And I think part of it's a Kaiser problem. And how much goes in each one of those buckets, I can't definitively tell you. Is that helpful?
Yeah, I think so. I just, as members are going to be voting on this increase 680% in these cases for the CDHP, sorry, for the Kaiser Kaiser
Northwest.
NWCDHP plan. It's a tough vote to say you're going to increase someone's premiums by 680%. But I just wanted to put that in context for what we all might be facing in the coming years.
I hope our purchasing is more successful than that, and I
And you guys do a
believe-
great job doing this. There's no question that you're, elite in this area, and I'm sure you'll stay that way. But my concern is that this is a huge, I mean, even though there's only 340 subscribers,
Yeah, it's huge.
it's huge for those folks, especially if they're using doctors, they have kids with healthcare issues and so forth.
Yeah, definitely.
Elliot?
I think what I'm hearing, and correct me if I'm wrong, of course, you have a little bit more leeway perhaps with other contractors. Their systems, and I'm talking about all the others regardless of whether they're Medicare or non-Medicare. Kaiser is constructed in a certain way with more limitations because of their structure. So I don't know that you have as much leeway, like you're saying, with billables and other aspects of those systems. It's not about one group being bad or one group being good. It's more about just the structure and how that is adapting to, like you're saying, current inflationary trends, changes in the healthcare market in the United States. I remember working on what do you call it? Group health plans, billing back, you're going to die, back in the 60s. I mean, this model goes back to the 60s, so that's before the Medicare Advantage plans came into play.
I definitely think, Elliot, Kaiser is definitely unique in terms of the purchasing we do, right? I mean, obviously we don't have relationships with a huge number of carriers. And, for specific to the PEB offerings, we do have structures in place in our contract with Regents around effective provider contracting, which hopefully will also protect us.
We'll go Monica, and then we'll go Tom. Monica?
Thank you. So I share, I think, was that Harry that was speaking?
It was John.
No, that was John.
John had asked me the question.
Yeah, I share John's concern, and I just want to draw the board and the public's attention to something that's very important that might have gotten missed during the debt ceiling / budget negotiations in Congress and the fiscal year 24 budget for the federal government. That $500 million was cut from healthcare, including the National Institutes of Health, the National Science Foundation, the CDC, And there's been proposals to eliminate entire funding bodies such as ARC and ARPA-D. So, academic institutions that utilize and have dollars from the federal government have been meeting to prepare around how are we going to deal with the cuts from the federal government. So I actually think that this is the one place I was very disappointed, and I wish these rates were even lower. But this is the one place where I think Kaiser Permanente is actually right, that as a bellwether, they're just experiencing things earlier because now many clinical care providers are trying to regroup to think about historically programs that have both research and clinically been funded are those that have been targeted for a reduction as part of the debt ceiling negotiations and the loss of those, federal dollars outside of Medicare and Medicaid that allow for clinical service providers to supplement care and to be able to fully integrate different kinds of programming. So I actually think this is a precursor for what we're going to see. We're lucky in this, enrollment cycle, in this negotiation cycle where, others have been able to come back to us with bid rates that are acceptable. But I actually think depending on, how this 24 fiscal budget goes down, that this is the beginning of a trend that we will see. And there are many people who are really trying to restore federal dollars for healthcare, for research, for a whole variety of other things, but just recognize that $500 million was cut as part of the debt negotiation ceiling from the federal funders that really provide, dollars for research, clinical training programs, a whole variety of things.
I appreciate that additional context, Monica. Tom?
I just want to make sure that I'm clear. So what you are saying is that Kaiser has an internal management system that the other plans don't have, and that affects their flexibility and could have an impact on the premiums they propose.
So definitely Kaiser has an integrated care model and through their own facilities and employee providers has a different, organizational structure than what we see, than certainly what we have on our self-insured product and, us paying the claims, bearing the risk for the claims. And then our relationship with Regents being through PMPM third-party administrator fee each month. So those are starkly different models, right? And then if you compare those with sort of what we have on the Medicaid side or what we have on the sub side with Premera, again, Kaiser is unique for us in terms of their structure. And that definitely plays into what they have always told us is a constraint in terms of the data that we have that we typically request from them, their responses to our procurement documents, as well as the claims data that they provide for us for risk adjustment. Based on what we see in the data we do have and the information we have from them as we did purchasing, they have, services or benefits cost, a particular unit cost position. Then they have additional cost for their integrated care model. And then they have additional costs for admin. And how those components of their costs come together and end up being a total level of, you've heard them talk about required revenue or needed revenue, sort of their price point. It definitely seems to be that those things impact them in such a way as an organization that they have a certain level of needed revenue.
Other questions or comments from the board? Monica, is that a new hand or an old hand? Okay. All right. Tanya, back to you.
So the next slide up, Dave actually spoke to this verbally last week during Beth's presentation about the UMP Plus service area changes. So we just wanted to put this formally within the presentation. So we had it included in our formal documents. Dave, you want to take the next slide?
Sure. As we transition to the resolutions, I wanted to discuss some of the feedback that came up at last week's board meeting, some changes that are in the resolutions that are reflected, the changes are reflected in red text as we go through the subsequent resolutions, and just talk through that. So the question came up from a couple of board members, and there was general, seemed like consensus interest in changing the wording of the resolution. So historically, the phrase endorses the premiums has been used. It's simply, I think I highlighted this last week, it's just a word that we've always used, and there was never a reason to talk about that word. And this year's dynamics have prompted a very understandable conversation about the exact wording of the resolutions. So we went back and we pulled out our thesauruses and did some brainstorming, and then consulted the statute and looked at, what does the PEB board have authority to do? And a key word that appears multiple times in statute in section 4105 is authorize. The board authorizes this, the board authorizes that. So we thought that's a pretty good neutral term. And so we've replaced all of the resolution language with the word authorizes. I do anticipate that going forward, we would just bring all resolutions in the future about premiums, including Medicare premiums in the future around those. The board is always welcome to use other words. We always provide you what we recommend. And it's just that this question that feedback was very well received in understanding the dynamics, but we just thought that a neutral language like authorize might be the way to go. I do want to say, I know some board members are very frustrated, understandably, with the rates that are before us. And like all resolutions, you have the opportunity to give context to your vote in any direction. We haven't had that in a while. We did have that for a little bit on some decisions in SEB as the program was being launched. But before you cast your vote, yes or no, you can always give context to that vote. That's true for every resolution, but I wanted to highlight it here because I know that there are board members who are frustrated with several of the rates that are here. And with that, Elliot, you have a question?
Yes, it's not really a question, it's a question, but not a direct one. So I see because these rates are kind of off, I'm thinking more of the explicit subsidy actually, but sometimes we're just implementing something that the legislature has decided. We can't exactly decide to change it.
Yeah.
Is implement a better word?
Well, in this context with
It's
the
probably
with the premiums,
Yeah.
it's probably more authorized, because there is it kind of goes back to that the phrase I've said the last week and this week, where the plans don't exist until the board
Right.
establishes them, affirmatively creates them, and so implementing doesn't. We did look at implement; it doesn't quite give that oomph of needing to have that affirmative step.
Mm-hmm.
I think you're right, Elliot, when it comes to the explicit subsidy, there is something that's more, you do have the authority to set a lower premium, so you do have some level. We've never brought to the board a resolution that wouldn't capture the full authority that's in the budget. We presume that no one would want to leave money on the table for anybody. But you're right, there might be, this context of what verb is used has now gotten on our radar as of this cycle, and so we'll be paying a lot more attention to that as we bring things forward in both
Just a
settings.
thought, because that concept of endorsing confused a lot of my members and started to confuse me as well with respect to the explicit subsidy. Okay, thank you.
Absolutely.
And just from like a procedural thing, I know that as we go through this, everyone has their own personal feeling about what word they think would be good. And for the procedure of creating motions and voting and doing and figuring out which magic word we're going to use, per Dave's comments about previous boards using the opportunity during their vote, I know we kind of go through the roll call, but if I call your name, you have an opportunity to speak and to say, before I vote, I'm going to say X, Y, Z. I know we have that in the precursor to the vote. We ask for the audience, we ask for the board, but many times in the past when board members felt strongly about a vote, either they're going to vote yes, but they don't like it, they would say their piece, and those are captured in the meeting minutes and in the recording as well. So I haven't seen it much as I've been with this board, but that was something that was quite common previously. Tanya, back to you.
All right. I think I am going to do this fairly quickly, actually, and pass it right back to you. So the next slide is the first resolution. Before I kick this back, I just want to remind the board that how these resolutions are structured are by the carrier. So there's a individual resolution for each of the carrier, and by the board adopting this resolution as written would be adopting the plan design that was presented last week by Beth, as well as the premiums that were included that we just walked through for all of those plans within that carrier. So
And I'll just highlight, so just to walk through this one, again, red text is different from what you saw last week. The original resolutions that were presented last week are in the appendix. Red authorizes in place of endorse, and then there's new text at the end of this resolution to distinguish Tanya's presented rates multiple times this month. And so this resolution would adopt the rates that she showed half an hour ago.
okay, Chair McDermott, I think this is back to you then.
All right, we're going to take a vote on Resolution PEB 2023-12, Kaiser Foundation Health Plan of Northwest, non-Medicare 2024 premiums. Resolved that the PEB Board authorizes the Kaiser Foundation Health Plan of Northwest employee and non-Medicare retiree premiums as presented July 19th, which is today. Is there a motion to adopt?
I'll make that motion to adopt.
Is there a second?
Second.
Are there any comments from the audience? Seeing none, are there any comments from the board? Seeing none,
Sorry, this is
Kurt?
Kurt Spiegel. Do we
Yes,
make
sir.
our comments now or when we vote? Because I do.
You can do both. If you want to make your comments now, feel free. If you would like to do it during your vote, that is fine as well, whatever you want to do.
Well, I think it would be easier, as my comment would probably apply to all the Kaiser plans. And that is that, I do not support or agree with these excessive increases on these Kaiser plans across the board. I understand by voting no on any given plan would essentially remove that plan as a choice for employees to make and do nothing for what the negotiated costs have resulted. So I don't want to remove a choice and the ability for an employee or member to make their own choice on what they have for their health insurance. So I will vote to authorize, but certainly not support.
Understood. Other comments from the board?
Wholeheartedly agree with what Kurt has said. And his comments reflect the fact that I plan to hold my nose and vote yes for these.
I also agree with what Kurt said, and I did play around with the wording a little bit, and I almost think that authorizes is still a little too much of an endorsement. I actually wrote acknowledged. The PEB Board acknowledges the Kaiser Foundation Health Plan of the Northwest employee and non-Medicare retired premiums as presented on July 19th. I will, as Monica said, hold my nose and vote.
Michaela? Oh, I'm sorry, Michaela? And then Ellie.
Yeah, thank you. I am kind of amplifying or agreeing with what everyone has just said around, I don't like this, and just want to put that on the record. And giving employees a choice is important to me, so I will vote so that employees have more than one choice. But also just acknowledge that want to work with you all in my official role to make sure that employees can make an informed choice and they have all the information that they need so that they don't get stuck with a plan that they did not realize they were signing on with.
And Elliot?
As a representative of the Retired Public Employees Council of Washington, I concur with the positions of everyone else who's just spoken and said everything I would say.
This Harry, my 2 cents is added on to the already great comments made by the other board members. I do think there are actually a couple of plans in here which I wouldn't hold my nose at, but the rest are problematic. I do think it's important for us to at least acknowledge that not authorizing these plans would create more turmoil than authorizing them. And, as Kurt said, I think, and others have said, let employees make that decision. I think we kind of learned that in the past. Let them make the decision. So I'm going to vote yes also.
Well, I guess I got to say something, right? I just want to say, working at the Healthcare Authority and seeing all the work that's done behind the scenes to try and make this better, and the engagement with Kaiser, I do have hope that in future iterations of the rates, we're going to see some of those benefits. I do know Megan just eloquently spoke about possibly the shift in the economy and when we're going to feel that, but I do think Kaiser is going to take some proactive steps to try and put downward pressure on their rates. I do think we're going to see that. I do hope we're going to see that in the next couple of years. I realize hope's not a strategy, but that's why we have Tanya and Megan to make it happen to the best of their abilities. So I am hopeful, and I am disappointed in what we're going to have to do this year, but hopeful that it will turn the tide. So, all right, it will be a roll call vote. Is there any other board members that'd like to speak? Okay, roll call vote starting with Michaela.
Yes.
Monica.
I will vote in the affirmative, but this is not a trend. So I'm happy to go along this year, but in light of, 5 months not being enough time for people to, find new physicians and have to change plans, I will not be this supportive if this continues to move forward as a trend.
Tom.
I acknowledge their rates and will vote that way.
I will take that as a yes. Elliot.
Yes.
Harry.
Yes.
Kurt.
Yes, with the understanding of my previous statement.
Understood. And Lou, yes, with the understanding that the agency is going to do everything it can to communicate with members so that they understand what is going to be happening on 1/1/24. That being said, Resolution PEB 2023-12 passes. A lot of times they go back to you, but back to me. All right. We're going to vote on Resolution PEB 2023-13, Kaiser Foundation Health Plan of Washington, non-Medicare 2024 premiums. Resolved that the PEB Board authorizes the Kaiser Foundation Health Plan of Washington employee and non-Medicare retiree premiums. Is there a motion to adopt?
So move.
Is there a second?
Second.
Are there any comments from the audience? Seeing none, any comments from the board?
I just want to reiterate, this is Monica, that my previous comments apply to all of the Kaiser plans, similar to Kurt's comments.
So noted.
I would echo that as well.
Noted. Tom, your mic's on? Tom, your mic's off. All right. This will be a roll call vote, starting with Michaela.
Yes.
Monica.
Holding my nose and saying yes.
Understood. Tom.
Yes.
Elliot.
Holding my nose along with Monica and saying yes.
Harry.
Yes.
Kurt.
Yes.
And Lou, yes. Resolution PEB 2023-13 passes. Next resolution is PEB 2023-14, the Uniform Medical Plan, non-Medicare 2024 premiums. Resolved that the PEB Board authorizes the Uniform Medical Plan, employee and non-Medicare retiree premiums. Is there a motion to adopt?
Moved. Seconded.
Moved, second. Are there any comments from the audience? Seeing none? Any comments from the board? Seeing none? This will be a roll call vote, starting with Michaela.
Yes.
Monica?
Yes.
Tom?
Yes.
Elliot,
Yes.
Harry,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution PEB 2023-14 passes. Thank you all. I know it was painful, but I appreciate it. Next up is the Medicare update. Oh, sorry. Tanya, Megan, thank you.
Thank you for a great job, by the way.
Appreciate
All of
it.
you.
Ellen Wolfhagen, Senior Account Manager in the Employees and Retiree Benefit Division, is going to provide a Medicare update to us on some information we plan for the upcoming open enrollment season. Our materials are on tab number 5. Ellen, welcome back.
Good morning,
You
Chair
seem to be the star
McDermott.
of the show this year.
Thank you. This is my swan song presentation for this year, so,
Okay.
just for this year.
I was going to clarify for everyone. She meant for July and the 23 board season.
And I very much appreciate the support from the board, so thank you. Next slide. This is a very brief update. I'm just going to talk about some activities that we are engaged in as we prepare for open enrollment. Next slide, please. So previously, I talked about some board presentations that were made in the 2023 season that pertain to retirees and Medicare. And those materials, while they are available on our website currently under the board presentations, in order to make it easier for retirees and others who are interested to find them, we're going to link them to the retiree engagement page so that they will be sort of standalone documents that will be easier to find. And we're actively engaged in that process. It takes a little bit of work to get it to all work. That will include things like the congressional letter, which is going to be a standalone document. It's not yet up there, but it will be. And I just want to reiterate the frequently asked questions that we have on the retirement page, as well as Medicare myths, and those are being updated. Our forms are being reformatted to make it easier to skip pages. Many of you may be aware that the form has, I think, 13 pages. You don't have to sign it or turn in every single page. We want to be sure that members have more clear instructions as to what to fill out and what to turn back to HCA. And my colleague Alyssa will be talking a little bit further about that as well. And one other change that we're trying to make is sort of a checklist kind of format that says if you're a subscriber and only applying for yourself, then fill out pages 1 through 3, for example. And if you're adding a spouse, then fill out pages 1 through 5, for example. So we're going to have more instructions like that. In terms of benefits fairs, which I usually refer to as benefit fairs. We are doing presentations in the East and the West. There are more fairs this year than there were last year, and we are actively preparing for a lot of retirees. Last year we were a little bit surprised by the great turnout that we had, and we recognize that a lot of retirees have questions, and it's really our goal to be sure that we can provide answers. As part of that, United Healthcare, Kaiser, and Premera are all going to be making presentations on their Medicare plans. Again, I am speaking simply to the Medicare portfolio, not the other things. The carriers will be there for other plans as well, but just in terms of Medicare. So Premera Plan G will have presentations, and they are also this year including materials on the discount programs that they have available as an addition to the Plan G coverage. It's not part of the plan, but these discounts would be available. The next thing is tools that we are providing for comparing the Medicare plan coverage. So some of the comments that we heard through the listening sessions, as well as comments that I receive through the HCA PEB Medicare inbox or directly through communications. We have to improve the readability of the comparison documents. So there's a couple of things that we're changing. First of all, it will be a 2-page spread, so it will be, you can open the book and see across the 2 pages rather than having to flip over to another page, so that should make it somewhat easier. And we are grouping it. HCA has a real appreciation for doing things alphabetically. I have a real appreciation for doing things in a common sense approach, which is not necessarily alphabetical. So we are trying to switch that up so that the most commonly compared plans will be next to each other and the benefits themselves will not be alphabetical. So if you look at, for example, the 2023 guide, hearing comes before outpatient services, and that really doesn't make sense. And so we're trying to group them in terms of like benefits. So office visits, specialists, inpatient, outpatient, things that seem to logically go together so that people have a better appreciation. There'll also be some introductory information on what to consider when looking at plan choices. So I refer to this as the 4 C's, the letter C. Looking at cost. So it's not just premium costs, it's what other costs might be involved. And in 2023, as people made a change from UMP Classic Medicare to, for example, the MAPD plans, that was the first time they had a Part D premium that they had to pay. And for some people who have what's considered excess income by the Social Security Administration, they had to pay what's known as IRMA, the Income-Related Monthly Adjustment Amount. So we're going to have more introductory language about the fact that this may apply to you, and it's something to be aware of, because those costs have to be factored in as well. Additionally, what are the out-of-pocket costs? What can you expect to pay for pharmacy costs? What can you expect to pay for medical costs? It's not just copays sometimes. And so we want to make more clear all the impacts that are possible. Another C is continuity, and that's really continuity of your providers. So is your provider accepting this plan? And again, it's accepting the plan, not in-network, because, for example, in the United plans, it doesn't really matter whether they're in-network or out-of-network in terms of your copay, but it does matter whether they accept the plan or not. And again, we'll provide some guidance on what that means. And then coverage is the next, which is really the benefits. So whether you're interested in additional benefits like chiropractic, acupuncture, massage therapy, whether you're interested in vision and hearing being covered, those kinds of attributes. And then finally, convenience, which really has to do with the facilities that are covered by the plan. Are those facilities near you? Or do you plan to travel and need coverage maybe in a different state? Do you plan to do international travel, in which case I'm very jealous? So, you want to be able to make those comparisons and look at all of those different factors. So those are the kinds of things that we're doing to increase our user friendliness and we are continuing to take comments. I just want to add one comment about the legislative report that Dave referred to earlier on the listening sessions, and want to let you know that what we're doing right now is the data analysis. So we're taking the comments that we received and we are doing a data analysis to say how many times did this kind of comment come up. And so we will have graphic materials as well as narrative materials to illustrate what we've heard during the listening sessions. Thank you, Elliot, for the positive sign. And that concludes my 2023 season presentations. And thank you to the board.
Ellen, I have a general question which is unrelated to what you just discussed. But if a PEB eligible retiree chooses initially to take a Medicare Advantage plan, non-PEB Medicare Advantage plan, and then 2 or 3 years later decides to drop that, are they still eligible for PEB coverage?
It depends. So if the person has, and actually a commercial Medicare Advantage plan is not a condition that allows you to defer coverage. It is not one of the other plans that we allow. So in that case, they probably wouldn't be able to defer, and then they could not come back to
What are some of the plans that are allowed?
So TRICARE, I don't know what you call veterans coverage.
Champ VA.
Champ VA. An employer, like for example, my husband could defer because he's now on my employer-sponsored plan.
Could they defer? I'm seeing cases now that I'm getting into the PEB. Could they defer on a spouse's Medicare Advantage plan?
No. So again, it's commercial Medicare Advantage plans do not qualify you for deferral.
Okay, so
Doesn't matter
you'd
whether
have
it's
to
you or
accept it
somebody else.
within the certain period of time
Yeah.
after
Yeah.
retiring.
Yeah.
Thank you.
Other questions? Oh, yeah, okay. Elliot?
I have a list. I think it would also be helpful, and correct me if I'm wrong, to have something on naturopathic coverage, because that is, I'm seeing that a lot from members. Do you want to comment as we go? I think that would be more
Sure.
helpful. Yeah.
That's a great comment. And the plans, how they treat naturopathy is different.
Yes.
And naturopathy in some situations is covered by Medicare and in some is not. So there are distinctions to be made on that, and that's a great call out. One of the things that I'm looking into is some call out boxes that we could have in the retiree guide that explain things like that. Naturopathy is a natural one for that. Massage therapy is also a natural one for that.
Yeah, that can be very confusing for people.
Absolutely.
And even the providers.
Yes, there's always the question of providers and what they understand. We are often asked to investigate and work with providers and remind providers that, in fact, even if they say they don't accept the plan, sometimes they do accept the plan. So.
And then going down the list, number two, what I think will be helpful, I'm really glad you're focusing on Plan Ds. Sometimes my spouse is on one plan because he has different medications than I do, and I'm on a different insurance plan. And that can work really well too, and people don't think of that. The other thing is, I have heard complaints by members. Ellen, I'll wait. No,
Sorry.
please, go ahead. Okay, that's allowed. UMP, when I was looking at plan comparisons, it appears that on the PEB site, when I was trying to compare Plan G with UMP, and for retired employees, it's through the grapevine that the only thing they show are UMP active employees on the website and don't show retired employees. So it might be something to look into to see if that is true, because people, and I heard that from more than one source. And then we're getting to right of appeal, and this is because you gave a great presentation at the last session. It spurred a lot of questions for me. I think it's good to remind folks that they have the right to appeal. All is not over. And your mention of these new Medicare requirements for prior authorization, another question came up. So let's say you get a request, you have to get something in 24 hours, right? Okay. I've heard horror stories of people getting the letter on a Friday, it's a holiday, and then they don't get it in on time the next Tuesday and they have no benefits. And so those questions are starting to come up more because each plan is different. So the more, education people have in advance, the happier they'll, well, maybe not, but at least we can try to give them some more advance notice.
Certainly, the more informed they will be.
Correct. I agree with that.
Yeah, and I think a call-out box again on appeal processes and the requirements
Yes,
would be great.
excellent. Yeah, I think that would be a really big help.
And just to clarify on Medicare pharmacy appeals, 72 hours is the requirement.
And that would be helpful too, because there's confusion. What about pharmacy? What about medical procedures? Everything's different.
Yep.
Thank you.
Yeah, absolutely. Thank you.
So that first bullet, board presentation links will be included on retiree engagement webpage. And you mentioned, and we've talked about the letter that you guys drafted. I was thinking that, when our members see these new rates published, and there will be the sticker shock, consternation, I think it would be beneficial if we were to also have like a link to active or proactive things we are doing as an agency. So for example, not only did you write that letter, but Dave and Sue met with the CMS and had a conversation with them. I think people should know that you have had that. And you have been appointed to a new board, is that correct? And what is that again?
Oh, you've asked me too quick to remember the exact acronym, but it's Public Sector Health,
Roundtable.
Public Sector Health Roundtables Institute. Oh my gosh, I can't remember the full name. It's a research institute wing of the Public Sector Health Roundtable. It is a spin-off organization, and the organization is really about trying to identify areas that would benefit from like white paper and research analysis to fill in gaps of kind of background information to influence federal policy is really what it is. So it's a multi-state effort.
So I think publicizing that would also be something helpful.
I should probably remember the name so I can publicize it
Yeah.
better.
And I think also it would help to just give, one or two examples, because if I'm reading this and my members are reading it, they go, what is that? Just another federal acronym, who cares?
Yep.
To be honest. So, this is how this can help you. Because what I often hear from members is, how's this going to help me?
Yeah. So those are just some things that I would definitely, so that the public doesn't think, well, we're just reactive. We are actually active in trying to find something that will help us mitigate the situation that we're in. I also wanted to comment on something that Elliot said. I am a person who makes use of alternative care. And I switched in November from Uniform to United Healthcare. I almost feel like they engaged in deceptive practices, because on the one hand, they say, when you look at that benefit page and they say, this is how many massage therapy sessions you get. Well, if you talk to them, they say, well, we don't cover, Medicare doesn't cover massage therapy, therefore we don't. So it's, when you talk to them, it is very confusing how you can even go about accessing it. I went to that link that Ellen sent me a link last fall, and I accessed it, and it says there are 15 naturopathic doctors that are preferred providers for Thurston County. In point of fact, almost none of them accept United Healthcare. They're still listed as United Healthcare, but Heart of Wellness is one of them, and I think there were 3 or 4 doctors. Heart of Wellness does not accept United Healthcare. So after going, and then there were some that did not accept new patients. So there was a list of 15. The last person I called, Dr. Patricia Allen, was the first one that on the link said that she accepted United Healthcare. I just had my second session with her, and her office professional had submitted the bills to United Healthcare, and United Healthcare rejected them, saying we don't accept naturopathic medicine. So if that's the case, on the one hand, they're touting all of these wonderful massage benefits you get as compared with Uniform, and you can access naturopathic doctors, and then you deal with them and you find, oh, I can't. So I think it's worth exploring in a conversation with them.
So Tom, I will tell you that I do know of many people who are taking advantage of naturopathic medicine under United, so that there are people who are getting the benefit. I would love to get specific information because that's the only way that I can address that. I need the name of the provider. You can send me an email.
Okay.
I need the name of the provider, and Heart of Wellness I will look into as well. There is a lot of confusion, and again, this is something that we could do to increase the information that's available. What our plan is a group Medicare PPO plan, a group Medicare Advantage PPO plan. A lot of providers are not aware of that, and they hear United and they say, I don't deal with it. Mm-hmm. But in fact, when we look at some of these providers, they're submitting bills to United and they're getting paid. So they are accepting the plan. It's a communication issue, which is why I need the name of the specific provider, and I will definitely follow up. But I am absolutely certain that there are people who get massages under United and get it paid, and there are people who have naturopathic services and get those paid as well.
And I will add one other thing. When you call, because when I first signed up, I dealt with their communication staff, and they're very good. I mean, at responding to you. You don't get put on hold for 20 minutes like in many cases. But what they did tell me is I got two different versions of how you access massage. One of them involves some paperwork where they will send you this form, and then you get the form, and then you have to send it back, and you have to do that for every massage. Whereas I'm used to uniform where I just,
Right.
done.
So that is a difference, and there are some providers that will not bill directly. And so that's true that there is a reimbursement process. You have to pay up front and then submit a form and get reimbursed. And there are some providers who actually do bill directly, and so it's just like uniform. And again, it depends on the provider. So it's impossible for me to sort of predict or say up front, this is what's going to happen. But anytime anybody has an issue, if you send me the name of the provider, I can escalate that and find out what exactly is going on. And we've had some issues where billings have had to be straightened out. And in terms of their customer service line, there is a specific PEB customer service line. However, when they get very busy, that line rolls over to their general line. And unfortunately, everybody on the general line is not as well versed in what's specific to PEB as we would like. Now, that's something that I'm working very closely with United on for open enrollment to be sure that their pre-enrollment line, which is where those calls end up, has information specific to PEB before we go into open enrollment so that we can avoid some of that confusion about you have to do this or you have to do that. I have heard a number of complaints of people getting conflicting information, and we're trying to address that.
Thank you.
Other questions or comments?
To supplement, again, what Tom said, I did have a provider, a massage provider, that would not, no matter what the circumstances are, work with HCA. I read a study that said HCA has a very high turnover in their customer service department. It's one of the lowest paid. Most of their money goes to attorneys and marketers and salespeople. That seems to bring the biggest profits to the company. I can't blame them, but I think that may be a factor that is out of PEB's control.
Elliot, just to clarify, when you were saying, I think you said HCA, I think you meant the carrier, not the call center here. So, because Lou looked up, I was like, no, she doesn't doesn't mean RAGs.
No,
she means
UHC.
You meant UHC.
I'm sorry.
That's
UHC pays its marketers and its attorneys, and I always think of me because I was in your role. So. Thank you.
Though I will say, our customer service center is not is among a low salary as well, something that the agency has been committed on working on and is trying to make strides. Because one of the only things that's older than pay one is the salary schedule for our call center staff. And there's very few things that are older than pay one.
Other questions or comments? Ellen, thank you.
Thanks, Ellen.
Thank you, Ellen.
Next up, we have an open enrollment preview. Alyssa Richards, Benefits Account Section Manager in the ERB Division, is going to present on the agency's efforts as we prepare for open enrollment. Materials behind tab number 6. Alyssa, welcome.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Alyssa Richards, and I'm the Benefits Account Section Manager. I'm here today to give you a preview of the open enrollment strategies in the Employees and Retirees Benefits Division. So open enrollment planning activities start months before open enrollment, the actual open enrollment period. Many divisions within Healthcare Authority work together for a plan for a successful open enrollment. PEB open enrollment is Wednesday, November 1st through Thursday, November 30th. In March, we actually begin with various areas of Healthcare Authority to discuss open enrollment tasks. These planning tasks include communications materials, planning for open enrollment system updates, etc. Starting in April, the planning for upcoming benefits fairs begins. The outreach and training team facilitates these discussions and starts planning for the number of fairs, the locations based on member enrollment data, securing the venues for the benefits fairs, and working with internal staff to plan for support on site for each fair. In June, the ERB communications team starts drafting the communication materials for the upcoming open enrollment period. In July, the board votes on premiums, which kicks off our ability to finalize materials for open enrollment. In August, the Healthcare Authority Finance and Communications teams finalize rate sheets and communications plans get finalized based on decisions that were made in July. This year, our member communication strategy this year, our member communication strategy has shifted based on significant changes. So we want to make sure members are aware of. At the end of September, we'll start our communication strategy by sending a postcard to all members to encourage them to look at the changes in premiums and benefits for the 2024 plan year. In October, we'll start sending weekly notifications to members about open enrollment, which I'll share more about in an upcoming slide. The next slide, please. The outreach and training team works directly with benefits administrators.
Alyssa?
Yes.
Sorry, we need to go back to the prior slide. I have to correct something on the record for people, and this is the creature of having two programs. The end of this slide on the bar says that open enrollment begins October 30th. That's actually the SEB open enrollment start date. The dates at the top of this page, open enrollment for PEB begins November 1st. It does not begin October 30th. We have two programs, and the open enrollment dates aren't perfectly aligned for a variety of reasons. Some of it's system load issues, but I just wanted to highlight as I was looking at this is like, the open enrollment dates, just to be 100% clear, for PEB are November 1st through November 30th. Sorry about that, everyone.
Yes. My apologies. Two presentations to think about here. Sorry.
So if you can start over on your next slide, my apologies for that too.
The outreach and training team works directly with PEB organizations' benefit administrators. The team supports over 700 PEB agencies and SEB organizations. They provide training regarding program plan options, covered benefits, eligibility, rules, and enrollment processes. In turn, those organizations act as the first line of customer service for their employees. When benefit administrators need assistance, they'll reach out to the outreach and training unit for support, either by calling a dedicated toll-free line or sending a secure message through HCA support. The team works on open enrollment activities year-round for strategies and process improvements, and they use member feedback from the previous years or to help with these planning activities. Next slide. The customer service unit is the first line of contact for retirees and continuation coverage enrollees. Staff perform three primary functions. They answer calls via the toll-free line and respond to HCA support inquiries. They provide in-person lobby services for walk-in members, and they review members' retiree or continuation coverage eligibility as they process enrollment forms. During open enrollment, any changes requested by retirees or continuation coverage members are submitted on a paper form, and customer service staff enter those changes manually into our Pay1 system. The customer service team has 27 Mass 3 positions, which are all currently filled. Of those 27 positions, there will be 20 staff fully trained by open enrollment, and the remaining 7 will be in some various stages of training, but will be assigned specific tasks that will support retirees and continuation members. Okay. Each year, the Outreach and Training Unit conducts webinars for the benefit administrators to help prepare them for open enrollment. They will be offering 4 webinars, which will be recorded and later posted on the Benefits Administrators Training webpage. Once the dates of the webinars are finalized, they will be shared and advertised with benefit administrators. The Outreach and Training Unit will provide forwardable email messages to PEB benefit administrators, who in turn send them out to all employees. These messages include important information such as open enrollment timelines, changes for plan year 2024, and information about how to make changes during open enrollment. Benefit administrators communicate with Outreach and Training through the HCA support portal, which is a secure email messaging. Our communications team is currently leading a project to make some updates to the external HCA support portal to improve that process and create some efficiencies in communications. Last year was the first year that we offered in-person benefits fairs since the fall of 2019. We received a lot of member feedback, which we used to start planning fairs for this year. Based on member feedback, we increased the number of fairs from 8 to 15. Locations for this year's fairs were selected based on member enrollment data. I've included the dates, times, and locations on the next slide. If you want to go back to the previous slide. During the earlier fairs last year, we did not have all of the printed materials available until November 1st. So based on feedback we received, we're working with our communications team to have the printed materials available at the first benefits fair as well as on our website. We are also planning to increase our staffing at the fairs to help support the needs of our members. We started planning earlier for more of our program staff to attend to address member questions. This year, we will again offer virtual benefits fairs. Virtual benefits fairs is an online website created with the same goal in mind as an in-person benefits fair. So some of the features include members can learn about their benefits from their home. It's available anytime, day or night, and can be accessed via a computer, tablet, or smartphone. And some carriers provide direct interactive webinars, pre-recorded webinars, and teleconferences to share plan-specific information. The next slide. So this, as I mentioned, this has a list of all of the dates, cities, and times of the fairs that we'll be offering this year. More specific information will be provided at a later date. Next slide. Earlier this year, Christine went over our typical communication strategies, but we've added additional strategies based on the changes to premiums and benefits for the 2024 plan year. We are planning for weekly notifications to members to remind them to review upcoming changes. Our first mailing will be a postcard sent at the end of September to all members to alert them of changes to benefits and premiums. We'll have increased social media posts, forwardable email messages shared with employers for them to send to employees, an alert banner in PEB My Account, as well as the open enrollment webpage. We'll also include a website alert on the front of hca.wa.gov so members can easily go to the open enrollment web pages to view important changes. We'll be using the October newsletter to call out information members need to be aware of when considering plans for 2024. The front page will describe the steps to take to make enrollment changes and include prominent alerts about premiums and benefits changes. Next slide, okay. There's some ways that members can prepare themselves for open enrollment. We know some members may want to change plans based on their individual needs. For members considering changing the plan, the best way to prepare is to make sure you can log into your online account, PEB My Account, and make sure information such as your home address is correct. They should consider signing up for email communications, preparing a list of important questions they may have for plans about benefits, prescription costs, deductibles, etc. HCA will be creating a list of potential questions members may want to ask plans when comparing, members know their needs better than anyone, so it's important they're engaged in comparing plans that best meet their individual circumstances. Members should make a list of their prescriptions so they can work with plans to understand how they would transfer their prescriptions, as well as what prescription costs would be if they do change plans. They should also review changes by reviewing information in our mailed materials as well as on our open enrollment website. Next slide, okay. Once members have reviewed changes for this year, and they should consider changing plans if that's applicable to them, look to see if they need to add or drop any dependents, attest to any applicable surcharges, elect FSA or limited purpose FSA decap, complete their Smart Health incentive, review life and long-term disability coverage, designate beneficiaries. And we will include these member checklist items in our open enrollment communications to help members make the best choice for themselves and their family. And that is the end of my presentation. Are there any questions?
Harry?
Yeah, I have one question, maybe two. This is a change only, I guess she's over here, I keep looking on the table. This is a change only enrollment, right? So if I don't have any changes, I don't have to do anything. Is that correct?
So Harry, the overall structure of the program is that you generally for your medical plans, you don't have to do something affirmatively each year. The few things, the caveat, because there's Barb Scott would always say there's an exception to every rule. The exception to you don't have to do anything if you like the way things are. If you're an employee and you have an FSA, a medical FSA, or a DCAP, you have to affirmatively elect that every year. If you don't take that affirmative step, that election doesn't carry over year. And then there's a subset of the population, especially for the spousal surcharge, that $50 monthly surcharge, that has to attest every year. We do an affirmative letter out to individuals who are in that population that are, if I remember, I can't remember if there's 6 or 7 questions you have to answer.
Right.
And the way you answer those questions in a certain way, you might be on the edge of having not paid or paid it in any given year. And so we ask, and we have everybody who's kind of on the edge of that eligibility always attest every year, because some years they may need to pay it and some years they don't. So outside of surcharges and FSA and DCAP, you're generally correct. If you're happy with your medical, dental, and plans, then you don't have to do something for those elections
The
to carry.
tobacco surcharge still exists, or the
tobacco
whatever it's
sur-
called.
yep, the
So
tobacco-
that has to be recertified. And
The tobacco surcharge doesn't have to be recertified affirmatively every year, but it does not get removed from your account unless you attest that your circumstances have changed.
Got
The
it.
only surcharge that has an affirmative annual is a subset of people for spouses.
Okay, and the other question kind of goes back to early on, you talked about the, I guess, I don't recall what it's called, but it goes into effect in January. We're going to kick off this new system.
Benefits 24/7.
Yeah, that's the one. Will the political subdivisions and tribes have access to that, or is that strictly state agencies?
It'll be everybody in the PEB program. So the political subdivisions that we call them employer groups that join us. That's the umbrella term for all of the entities that contract into the program. They'll also access under the new system when we launch it.
Yeah, and so these, of course, a lot of these, some of the benefits that are eligible for state employees aren't necessarily made available by those political subdivisions or whatever we call them these days, non-herbs or.
We call them employer groups because there's like 5 different
Yeah,
categories.
so having a little bit of experience with that, and for a long time ago, sometimes those groups weren't real proactive in taking advantage of the training opportunities, and so I was just cautioned, to make sure we don't lose sight of them. Thanks.
Other comments or questions from the board?
Yep. This is Elliot. I do have a comment. I guess it's for 24/7. I was one of your test cases. I could not work with getting into the Washington State system.
So.
Pardon me?
It's called SAW, Secure Access Washington.
Oh, SAW, that's a good name. Because I couldn't even access 24/7. So it's, maybe there are other elderly folks like me, members, who might need some support in how to even get in. So I'm sure you've thought of that, but I just needed to ask.
Yeah, there are a variety of strategies. We were prepared for June 12th when that was our launch date. And one of the things that happened in June is we sent a communication about how to log into the system and prepare and get ready for the system, and then we did not proceed with the launch on that day. We're going to resend that, but we'll be able to make some modifications that are necessary there. But some of the things that are included is a step-by-step guide about how to navigate SAW. And we also have other materials that were planned and specific people who are designated for helping triage calls related to Secure Access Washington. So there are a couple of strategies, and we'll definitely those are in place. They were prepared for June, and they'll be done in January. But I do want to assure that we don't expect people to hold on to the mailing that we sent them in June for January. We'll resend that as a important communication that it's a quick start guide that helps navigate people through what to expect as they log into that system. So we'll definitely have those things for January, Elliot.
And there's one other technical question, and probably Lou can answer it.
Doubtful.
On page 3.
Page 3.
You refer to, you provide training to organizations regarding program plan options. What kind of organizations are those? Are they agencies, or they're not agencies? If they're not agencies.
Oh, like hearing.
Alyssa,
Okay.
do you want to cover that one?
Yeah, so when we're talking about PEB agencies and SEB organizations, we're talking about those PEB agencies, employer groups, as we just shared, and then for SEB organizations, the school districts, their benefit administrators. So that's who we're referring to.
Yeah, back in the day, I had attended those, and they're very helpful. They used to have them over one of the state agencies, a big conference room or theater kind of setting, and HCA reps would go through the various plans and all that, and it's a train-the-trainer kind of thing is the way I would look at it.
Yeah, when we serve over 700 different employers, that includes, so the umbrella term, sometimes we say organizations, but that includes state agencies, higher education institutions, political subdivisions, tribal governments that contract with us, the health benefit exchange, employee organizations that represent state civil service employees. Yes, those are, I'm remembering the exact list in the statute, but it's an umbrella of school districts, educational service districts, and I don't, counties and cities and municipalities, which sometimes are listed separately in statute from political subdivisions, even though some people think they are political subdivisions, because they are, but whatever the statute says, it says. So all of those entities, you can think of them as those direct employers of the individuals. That's who we mean under, when sometimes we say agencies, sometimes we say organizations. It's all the umbrella for all of those 700 plus employers.
Thank you.
Mm-hmm.
And actually, I did know that, so, yay. Do we have other questions or comments for Alyssa? All right, thank you so much. Good luck. It's a big task, as it is every year. Kristen, you're not getting bumped this time. Kristen's here. She is the wellness manager in our herb division. Is going to be providing us with a smart health update that'll include some information about our transition to a new vendor from Limeade to WebMD. Her materials behind tab number 7. Welcome again.
Thank
At this
you so
time,
much.
you're on.
Thanks so much. Good morning, Chair McDermott and members of the PEB board. For the record, my name's Kristen Steimanoff, and I'm the Washington Wellness Program Manager. And as Chair McDermott shared, I'll spend most of my time today describing the upcoming transition of Smart Health from the Limeade platform to WebMD. I'm going to start with a brief follow-up to the information that I shared with you during the April 13th meeting, and then I'll go into that transition discussion. So next slide. Okay, in April, it was April 13th, I shared our Smart Health participation numbers over the last 3 years. And we've had some disappointing dips, especially between 2021 and 2022. And as I shared during that meeting, there were two key changes that we believe contributed significantly to that decrease in participation in Smart Health and in members qualifying for their wellness incentive. And Elliot, you alluded to one of them. It was the shift to SAW. Everybody had to make a move in October to log into Smart Health and other online applications in compliance with the Washington State Office of Cybersecurity to SAW. And that was really tough for a lot of folks. But it's not going away, so we're still trying to support people in making that move to SAW. The other transition, the other event that we believe really contributed to that decline was a positive one, but still challenging. In April of last year, we moved from the Limeade Classic platform to the Limeade One platform that has a lot of additional functionality and features that we like, but it required a new login process, and a lot of people didn't make that shift with us. So those two things we think really contributed to those declines. We're working hard within our team and with Limeade to try to help people still do what they need in 2023 to take care of themselves and to qualify for their wellness incentive. So on the next slide, I'll show you some of the things that we are working on right now. So we sent a reminder in May in the 4-year benefit newsletter that goes to all PEB employees about the wellness incentive, the deadlines, the requirements, really wanting to remind people early, be proactive, qualify for your incentive, because as a reminder to all of you, that incentive is a $125 deduction to your health insurance deductible, or if you have a high deductible health plan or a consumer directed health plan, it's a deposit into your health savings account, but it occurs in the following year. So if they do what they need to do in 2023, they're going to get that reduction or deposit in 2024. So we really want to make sure people know what to do and are on top of their deadlines. So we sent that announcement in the newsletter. There's a nudge on the Smart Health homepage. If you haven't done your well-being assessment yet, there's a reminder to do that, because that's one of the things you have to do in order to qualify. We sent an email to registered Smart Health users through Limeade at the end of June to everybody, again, reminding them about that deadline, reminding them that they have to go in through SAW, and linking to the instructions for how to get onto the new platform if they're not there already. We've also had some really nice collaborations with our statewide business resource groups. We're really working to deepen that true diversity, equity, inclusion, and belonging in the Smart Health platform. And we've had some nice collaborative announcements in Smart Health from some of them. We're working to get more, but we were really pleased to see in June, for example, we had a post or an announcement in Smart Health on Juneteenth that we worked on with BUILD. That's the business resource group Blacks United in Leadership and Diversity, and they helped us create a really nice Juneteenth post. And we also worked with RAIN, the Rainbow Alliance and Inclusion Network that represents LGBTQ populations. They did a really nice post for us for June being Pride Month. And those two were in the top 3 most carefully viewed announcements in the platform. So it's nice to be popular, but what we really want is for people to see that there is a place for all of us in Smart Health, and we want people to feel, their interests and values and priorities reflected. So we're trying to do more of that with the business resource groups. We're also talking to OFM about collaborating to increase employee engagement in the employee engagement survey, and to use the results of the Smart Health Wellbeing Assessment Report to help managers at the different PEB and SEB organizations really focus on employee engagement and employee well-being. At the end of the year, we're going to do a giving campaign activity that we've done several years running, and people get lots of points for it, for volunteering or donating or just being kind to their neighbors. But the idea is really helping others is helpful to yourself and can help you qualify. And then finally, we'll use those benefit fairs that Alyssa talked about to give a final push and to start talking about the transition to WebMD in 2024. But I really want to emphasize that we are also going to be using Smart Health to communicate to members in 2023 about the importance of looking at their plan selections during open enrollment and making sure they're making an informed choice. We're adding to that list of things that Alyssa shared that we're going to do to make sure that people don't overlook this important decision. So now I will switch to the WebMD transition. As you all heard in previous board meetings, there was a competitive procurement for the wellness vendor, and at the end of November, WebMD was announced as the apparent successful bidder. We had several months of contract negotiations, and that contract was fully executed in May, and we're working closely with WebMD now to prepare for full implementation for all Smart Health users as of January 2024. Many things are going to stay the same. Oh, sorry, go ahead.
Yeah, I had a quick question. Are you going to discuss the purchase?
Oh, yes, at the end. But I can talk about it now if you like.
Well, I just think it's going to help with the transition. Sometimes when we go from
Yeah.
one vendor to another, it can be a little rocky.
Yes. Yeah, let
But
me
in this
mention that right
case,
now.
yep.
Let me mention that right now. We learned in early June, there was an announcement both by WebMD and by Limeade, WebMD's intention to acquire Limeade. And Limeade is the current Smart Health vendor. It's going to be WebMD in 2024, but if all of the necessary approvals are completed, they anticipate this acquisition to go through in this quarter, probably sometime in August, maybe mid-August. And, we're still figuring out all of the details, but as Chair McDermott suggested, we do think there's going to be a lot of positive support on the transition side because, we won't end the relationship entirely with Limeade and have to just figure out any loose ends that might be hanging on as we transition to a new vendor. So those details are still being figured out, but I've been hopeful about that and still am, and I think that's definitely going to be the case. Is there anything else that you think I could address there?
No, that was it. I just,
Okay.
sometimes it is a little, when we're leaving one vendor, it goes dead air and we
Right.
can't get things done.
Yep.
And telling them to work with the new vendor is problematic, but in this case, it kind of weirdly worked out.
Yeah, I think there's going to be a great deal of positive support there. So thank you for giving me a chance to talk about that now. Some things that aren't changing will include those eligibility for the incentive, that $125 incentive I told you about, the requirements, the deadlines. Most people have to do all the stuff by November 30th, but new employees have until December 31st to participate in activities and do a well-being assessment in order to qualify for that incentive. They're still going to have activities that they can participate in or group challenges, and it's still going to be Smart Health. People will go to the same place, smarthealth.hca.wa.gov, to log in on their computer. The branding's going to be the same. I'll show you a sample of it in a second.
I'm sorry to interrupt.
Yes, of course.
Is the incentive just for UMP members?
Nope, it's
Oh,
for
it's everybody.
all.
Okay.
So the
I know one time
Kaiser.
that was kind of convoluted.
Yeah.
Thanks.
Sure,
That's
of course.
helpful.
I might as well ask a
Sure.
question also, since we've heard about SAW accounts and logins, is it gonna be your SAW account login that gets you into this one?
It is.
Yeah, it's this, the state, your SAW account is designed to be your universal access to various state services as SAW is put in front of more and more services, whether that's your car tab registrations at the Department of Licensing and your, every other time you get to renew without going in person for a new photo for your driver's license, or your benefits account, or unemployment insurance. All of these things that are across state services all have SAW gradually being put in front of them, and it's designed to be the same account.
And my understanding is that because more and more is going there, there has been more complaints about the user friendliness of SAW. And so I do believe WATEC is undergoing an exercise to update SAW. So I think that's going on. Yeah.
To stay off topic a little bit on the SAW, for what it's worth, I use Chrome, and it saves the login password, so I don't have that problem of remember where it is or where I wrote it down, because it browser has figured it out for me.
Maybe I should call you because I have Chrome too.
Right.
I'll just say that always makes me cringe because I don't like to save my passwords on anything. That's like, to me, that's the equivalent of putting your sticky note password under your keyboard. So I don't know. Maybe we'll have some security people share their thoughts about password saving on browsers. But whatever gets you through the system, just be aware of the choices you're making.
Dave is really good and serious about passwords. I admire that about you. A few key things are changing, which I'm going to talk to you about more. We're definitely shifting from the current Limeade platform to the WebMD, web-based platform. Again, it will be Smart Health, but the platform is WebMD's. And then same on the mobile app. For people who use a phone or a tablet or something to access Smart Health, there will be a new mobile app that they will shift to. And there are going to be new features, which I'll start talking to you about now. Before I do, I just wanted to show you this quick screen. Oh, no, go ahead. You can, next slide. Yeah, this is just a screenshot of the demo site. I wanted to show you, if you're familiar with Smart Health, the logo is still the same, the colors, general feel, it's going to look familiar to people. So they'll still see Smart Health, the fonts will be the same, just wanted you to see that that branding is still very much the same. But on the next slide, I will walk through some of the new features. So there are a lot of new features and functionality. I'm listing a handful that we're especially excited about. I'll describe them a little bit here, and then I'll show you some screenshots. The Daily Habits feature is one that I'm really excited about. You have a chance to choose from a list of plans that you want to develop habits around. And people can choose up to 3 at any given time. WebMD has recognized that if people get too gung-ho about choosing all these new habits that they want to develop, they probably won't have a lot of success. So you can choose up to 3. They can be condition specific. They can focus on general health behavior or general well-being. So you might choose habits to help improve your back health or your diabetes management. You might want to focus on habits around your nutrition or exercise or even managing stress or staying connected. There are also health trackers, and you have access to lots of health trackers. They can be around biometric things like blood sugar, cholesterol, blood pressure. You might want to keep those numbers in the platform and track them over time. You can track your completion of certain important screenings like colorectal cancer screenings or mammograms or blood pressure, and then even behaviors like nutrition and sleep. Also lots of informative videos, podcasts, and articles. So next slide. Do you want me to wrap quickly?
Okay.
Okay. So I'll show you a few more screenshots. This one shows the daily habits that I just mentioned and the health trackers. We have access to a test user account. So in my test user account, on the daily habits, I chose balancing my diet and keeping stress in check. On diet, I really want to be eating more fruits and vegetables and fewer crackers. So I'm going to see if I can build that habit in the daily habits. And then keeping stress in check. For the health trackers, I went all in and I chose to track my nutrition, exercise, hours of sleep, mindfulness, and steps. So every time I log into Smart Health, I can see where I am on these habits and on these trackers and what I need to do to get where I want to go. They give you a personalized to-do list based on what you've chosen. On the next screenshot, I'm showing you the podcasts at the top of the slide and the videos at the bottom. With the podcasts, WebMD has a partnership with Beyond Well Solutions, and it includes a podcast series on a variety of mental health topics. They are ranging from 2 to 12 minutes in length, but most are right around 4 to 6 minutes. And subjects include things like trauma and caregiving, virtual mental health care options, mental health in the workplace, really important deep dive stuff on mental health topics. And then also on the bottom of the slide, you can see there are videos on a wide variety of health and wellness topics. And WebMD told us that they have health coaches on their team that recorded a lot of these videos. And this is just a small snapshot of some that are available, but there are things around nutrition, exercise, all kinds of healthy stuff. And here you can see videos on healthy condiments and healthy snacks, and one on core exercises, which is especially helpful for back health.
Kristen, I'm assuming that these are healthy snacks?
Absolutely.
Very sure.
And then on the next slide, there are lots of articles, and many of us already see WebMD as a trusted source of information when we're looking for information about our own health. So after the transition in the platform, there are a lot of WebMD curated articles on the site. And then finally, I talked about this. Chair McDermott gave me an opportunity to talk about it at the beginning. I've shared everything in the first and second bullets with you. We learned at the beginning of June as expected this quarter. One thing I do want to emphasize that I don't think I talked about, we did initially think, oh, I wonder what we've been planning with this transition might change. And really there are no anticipated changes to what we've been, the path we're on. So it's still going to be that transition to the WebMD platform. Even though they are going to acquire Limeade, we're not staying on the Limeade platform. We are transitioning to the WebMD platform. We are transitioning to the WebMD app. The new features that I just shared with you, all of that is still marching forward. Since they were questions in my mind, I told Dave I really was hoping to share that with all of you because I thought some other people might have a question too.
So I have a question on their app. Is it going to be a separate app just for their wellness program, or is it going to be fully integrated with the other things WebMD does? So like when your head hurts, you look it up and find out you're going to die, all those fun things.
No, it's specific to their wellness program. It's called Health at Your Side, I think, WebMD Health at Your Side. And when you log into, with Smart Health, when you log in on your phone, you actually log in on the Limeade app. Now it's the Limeade One app. And it's going to be the same with WebMD. There's not a Smart Health app. It's going to be the WebMD Health at Your Side app. But when you log into it, you see the Smart Health logo and, our featured activities. We're going to be sharing information about benefits that are offered through the PEB program.
Okay.
It won't be fully integrated with WebMD.
It's always bad news when you look at that stuff.
You won't be able to go down that much of a rabbit hole.
Okay, yeah. This is obviously not for this year, but when I was looking through your presentation, I saw all this good stuff, and the Retired Public Employees Council members would love all this stuff. I mean, it applies to them too. Is there any way, and I know this is not, I don't mean to ask it to you specifically, but is it something that HCA could look at offering to retirees?
I think it would be helpful for us to bring back kind of the history of why it is and isn't with the retirees, and that, and can help elucidate how flexible or inflexible it is. I think that's a great topic for us to put on the agenda to bring back.
I would find it very interesting because I thought, wait a minute, I don't want this stuff. Okay.
And I'll just say, I'm not trying to be evasive in that answer. I can't remember the reasons. I know that there were specific reasons. So I think it'll be good just to kind of resurrect that. And sometimes as we do that, we go, oh, the world has changed. But we can certainly put that on the agenda.
You could join the workforce again. Come on back.
Yeah.
I did.
All right. We have other questions or comments?
I do have just, so I went to the App Store and Wellness at Your Side is the app. And you would load that onto your phone. So you would access that, but not through our website, correct?
You will be able to do both. As with the current one, if you want to do it on your computer, you go to smarthealth.hca.wa.gov. and it pulls it up. But if you want to do it on your phone, you pull up the Limeade One app,
Which
when
will
we
be the
transition,
WebMD app, right?
which will be the WebMD app.
Okay,
But the web-based one will still be smarthealth.hca.wa.gov.
okay, okay.
Other questions or comments? I'm glad we finally got to hear your presentation.
Me too.
Thank you
Thanks
so
so
much. Dave, 2024 board schedule behind tab number 8.
All right, this is the same document from last week. We're in the process of filing with the code revisor's office, but just wanted to reinforce that 2024 planning begins, well, not tomorrow. Tomorrow's the sub board meeting, last meeting of the year. Begins Friday, so start marking your calendars for these. And again, just really want to highlight, you see 4 dates that run from July 11th through August 1st on this schedule. That would be pretending that we have a meeting every week for 4 weeks in a row. We don't anticipate that we would use all of them, but it's easier to cancel a meeting than schedule them. So as we get further into the next year's schedule, we'll be able to let you know, but really appreciate everybody kind of earmarking them. And for everyone who experienced the shift from Thursdays to Wednesdays the last 2 weeks, this schedule is all Thursdays all the time, just to be as consistent as possible for the PEB program and for staff, where we it just flipping the order of meetings just gets confusing. So this, hopefully that helps. It's all Thursdays all the time for PEB going forward. So just wanted to highlight that. And back to you, Chair McDermott.
Yes, I have a request for the retreat. I've heard from members questions about could we meet our PBM and our MOTA reps? So that would be, I guess, the Navitus, and just talk about what they do and how our RX drug system works, and how prices are negotiated and all of that stuff.
Perfect idea, Elliot. Well, 2024 planning begins Friday, so perfect time to brainstorm is today.
Any other questions or comments on the schedule? Tom?
Well, it's not appropriate at this point, but when you take general comments at the end, I will.
Okay. All right, we're doing public comment right now. Is there anyone on Zoom that would like to provide general public comments? Yep, put your Zoom hand up and we will get you down.
While we're getting lists, I'll just highlight, because I was noted how important password security is. The number one thing you can do to increase password security is length of your password. As an example, just going from 11 characters to 12 characters, for an automated bot that's trying to hack your system, that is the difference between a few months and a few decades in being able to crack your password. Just going from 11 to 12 characters. So my personal journey in my friends and family life is to get people to move to 12 characters. I won't ask you to do 20 like I do, literally, which gets me over 500 trillion years from brute force. That's probably a little excessive for most people, but just go to 12 people, go to 12.
And then,
or higher, or higher.
and my other piece of advice is, if you want to get to those 12 characters and make it really hard, use a Gaelic word.
There are lots of opportunities to it, but just get to 12 people.
I think the trick is to remember it, whatever it is.
And I'm thinking this might be a great opportunity for a literacy and data article in one of our newsletters, maybe as we're launching our IT system, Gene, just about password, not recommended passwords, but how to create a strong password.
And characters obviously include numbers, right?
Yes,
Okay.
and when I say when characters, that's a combination of numbers, special characters, upper, lowercase. If you only use one of those, you dramatically increase the odds of your password being able to be cracked in minutes.
So we've
not
obviously
months.
hit something near and dear to Dave's heart.
Yes, I just wanted to take the opportunity to fill in the time. So back to Mackenzie and Lou.
All right, Alyssa Mueller? Alyssa, are you still with us?
I sure am. So sorry about that.
That's okay.
Good morning, everyone. My name is Alyssa Mueller, and I have been working with the HCA staff over the last week, who have been very helpful and compassionate in trying to figure out what can be done regarding Regency's denial of my son's medically necessary care. I also wanted to share this issue for the board to become aware of, to inform your work around covered benefits for ideally next year's plans, but realistically, I understand is more likely to be 2025 plans. Thank you for allowing me the opportunity to share with you today about a parity issue I see in the state insurance plans regarding habilitative services, specifically speech therapy for my son. My son has a diagnosis of childhood apraxia of speech, or CAS, which is a motor speech disorder that makes it hard to speak. If my son had an autism diagnosis, the plan states that visit limits do not apply. Both autism and CAS are present from birth and deserve the same level of care. Research in speech disorders caused by impairments in motor planning, such as CAS, has shown that the most effective form of intervention is intensive and frequent, 3 to 5 days per week, as recommended by the American Speech Language Hearing Association. My son's receptive language is excellent, and he understands everything that is said to him, but at 3.5 years old, has only one vocalization used for affirming and uses only 6 signs. This significantly impacts his ability to participate in the activities of daily living and to access his world safely. While my son has begun using more sign language and is beginning to learn to communicate through an augmentative and alternative communication device and therapy, he needs treatment to even begin developing words to progress to a functional level of speech. While I understand that outpatient habilitative services, including speech therapy, are a limited benefit that applies even if additional visits are medically necessary, and that it is your role, the PEB's role, to balance affordability with benefits that employees need, it seems as though habilitative services should not be a limited benefit, at least not for kids at a certain age. I would also note that every insurance plan offered by the state to state employees has the same cap of 60 sessions, so I can't even pay a higher premium or shop around to find a plan that would better meet my son's needs. Please consider what you can do for the future to change the agreement with Regents regarding a limited benefit for medically necessary services so that there is parity between treatments for autism and other serious conditions present from birth. But please also see what you can do now for my son and likely other state employees' children who need equitable access to services now, because waiting another 1.5 years until the 2025 plan year when you're 3.5 years old is literally half my son's lifetime. In closing, I invite you to fight with me to ensure that children with various serious conditions can access equitable levels of medically necessary care. Thank you.
Thank you. Lena Mulder? Oh, Linnea, sorry.
Sure.
Every time.
First to Alyssa, I am, as a grandmother of a 3.5-year-old, I feel for you and really hope he can get the care he needs. I had one comment and a question. One is, the comment is to Ellen. Thanks very much to Ellen for including the call-out boxes for medical and pharmacy PAs in open enrollment information. Many members understandably think because their provider prescribes a medication or treatment, they can access care with no delay. This is not always the case, and it's helpful for members to know upfront what the PA process may include. The second is just a question for a member question for Alyssa. The Smart Health incentive, does that stay with the member or the insurer? So if a member changes plans in open enrollment, do you keep the incentive or do you lose it? Thanks very much.
I believe the answer to that is it goes with you.
As long as you meet the general eligibility plan requirements, when the incentive is distributed in January, the incentive is given to you. And the reason I'm calling out that distinction is if you during open enrollment waive your coverage and you're not enrolled in a plan in January, then you wouldn't receive the incentive. But if you were in one plan in 2023, elect a different plan, we distribute the incentive in January, so it's applied to the plan that you're enrolled in January and based on your plan enrollment. So
Okay.
that's why I was drawing that distinction, is because you can't waive coverage and then get an incentive.
Sure. Thanks very much.
Thank you. And Christine Clark?
Christine Clark. I'm a member of RPEC Chapter 13, which is the Spokane area. I too, as Elliot is, I am interested in that Smart Health program for us retirees. I think it would be a benefit to us and it would reduce some of our healthcare costs. Thank you.
Thank you. Any others from the public? Our next meeting is going to be
Well, February 1st. February 1st. Right.
I do have
Yep.
a comment to make.
Okay.
So am I understanding it that this is going to be Connie's last meeting where she will be present?
You are correct.
So.
We are going to get to Connie in a moment, but
okay,
but just so you know, if your comments are Connie, you can hold on like 2 minutes.
Okay, never mind.
We weren't going to let that opportunity pass us by.
Dave, you want me to turn that over to you now?
Yes, actually, this is the very next thing. It was just for my closing remarks, which include the board season and a little bit about Connie. So I'll do my non-Connie things first. So I just want to highlight, we are going to start planning for the retreat as of Friday. We'll finish up hopefully the sub-board season tomorrow. Some things that we know that already that are likely to be on our February agenda is talking about the 2 legislative reports that will have been submitted in December that I discussed earlier, the results of open enrollment and how our membership responded to the rates that were authorized last week and this week, and then setting the stage for conversations about whether there is interest and what the effects would be if the UMP formulary for UMP Classic Medicare were converted to a Part D. Again, no decision made, but we'll be bringing information because a lot of people are asking questions about that idea. So just want to reinforce, decision not made, but we're going to, the agency needs to do research to see the viability and timelines for that. And then there's been a variety of continual questions related to pharmacy, the pipeline of drugs, exactly how coverage determinations are, some suggestions of individual drugs that have been coming up. I anticipate we'll be talking a lot about weight loss drugs next board season, as that is really an up and coming issue. And so a lot of that kicking off with, and at the retreat we'll also hopefully talk about the then couple week launch of Benefits 24/7. So those are some things that we anticipate. I do want to say I know that this board season, especially the end of it, has been very challenging on a lot of different fronts. I've said it in a couple of different forums, and I genuinely can't remember if I've said it at the PEB board meetings or not, but none of us want to be in the position that we're in that culminated in the decisions that had to be made this month related to plans for 2024. There are some tiny bright spots in different parts of it. There are several negative numbers on that chart, meaning that some premiums go down in certain plans. And I think people recognize that is, some people think that never happens. We have proof in our slides that can happen in certain circumstances. And so here at HCA, we're committed to doing everything we can to keep that downward pressure as much as possible and keep those trends as low as they can be, and use the Uniform Medical Plan as a way to influence the overall commercial market in our state. It's a very powerful lever for the state and a powerful tool for our members and for the agency in influencing the healthcare market in Washington. So we'll keep on that. And so now, Connie's gonna re-retire. I never know if we're saying she's retiring, re-retiring. She's gonna stop volunteering. Sometimes she says. Connie came back to the agency to help for a couple of years, I think is the way the story goes. And here we are about 20 years more later, where Connie really is. This is her last PEB board meeting. Her last board meeting will be tomorrow, but she is exiting the active workforce as of the end of the month. And so I have to say that when I moved into the directorship and I was like, Connie, we're going to have 2 boards and we're going to meet every 4 weeks for the next 3 years. She was like, okay, how's that going to work? And we had many long nights working together every month, and we had our cadence of getting things done. And I really, there are a lot of different moving parts for managing the activities of the board, 2 boards, the frequency of the meetings. We talk about the amount of work that goes into preparing for board meetings, and there is, we also talk about the cycles of the program, and we have a board season, and it runs from January and July, and then we can pivot away from some board work and put all of our energy into the member communications and pieces. And for a while there, we didn't have a break like that, and I don't know how things would have worked out if I hadn't had Connie to help kind of navigate 2.5 calendar years ended up feeling like 7 board seasons when you count up all of the nonstop nature of SEB program work. And I just can't thank Connie enough for the work that she did to help the boards be able to perform their functions on behalf of the now 725,000 covered lives that we have between the PEB and SEB programs. So there's a lot of, she has a lot to be proud of for the work that she's done here at the Healthcare Authority through multiple directors. I happen to be the recipient of everyone retiring. You know, Scott Palafox retired, Renee Bourbeau retired, Barb Scott retired, and then Connie's now retiring. I think that's the natural cycle of talking about our aging workforce and moving into retirement. Hopefully it's not a reflection of leadership. I've just been the one who has to work on all the succession planning. But I just want to thank Connie, and I want to turn it over to others who want to say things, because we know Tom has some remarks.
Tom?
Well, I joined the board 5 years ago, and I literally was appointed to the board one day before the retreat. When I came to the retreat, I had no idea what was going on. And so I needed somebody to explain things to me, and Connie was my go-to person. And through all of the next 2 years of me floundering around, she was always my go-to person. If I had a question, she would answer it. She was the person who helped me create my first SAW account, and my second, and my third, and my fourth, onto my 8th account, because I would forget the password. And I would remember not how to do it, so then Connie would. She never criticized, she never rolled her eyes, she never shook her head.
Oh, she rolled her eyes.
Oh, I just never caught it.
And
Yeah,
said,
but
Lord love a
anyway,
duck, because that's her phrase.
I just wanted to let her know how much I appreciated everything you did for me and made it a good, easy transition. And I still don't know much, but you know, that's the way it is.
Elliot?
I am going to mirror a lot of what Tom said. I was appointed in the middle of COVID. So actually, in 2020, and my first meeting was the emergency COVID meeting. And I had no idea even what this job or whatever it's called was about. And I was absolutely terrified. Sue wasn't going to be there. And Connie was the one who kind of told me what to do. And I'll never forget you, Lou, because I wasn't even introduced.
Right.
It was like, what's your question? Go. I was like, okay. And Connie would say, you're okay. It's okay. You're doing okay. It just, don't worry about it. Just breathe. Just anything you need. And I said, but I'm not an employee. Why am I filling out these employee forms? She goes, just do it. Just do it. But they're gonna get me. No, they're not gonna get you. She was like a therapist, okay? She was wonderful, and I can't, and so every time I saw her, if I was feeling nervous, I'd feel a little bit of relief, like I was gonna make it and I was gonna do okay. She's been wonderful these last few years, and I feel like I'm growing in the position, but I always feel she's cheering for me, and she wants me to do well.
Others?
Yeah, I would like to say a few words as well. I've been hanging around here for at least 15 years, most of them as a member, thanks to the very kind director. And so I go back to the days over in Lacey and can tell stories like everybody else about how kind and helpful Connie has been. She's always referred to me as her little buddy, which I appreciate that. I hope she isn't calling anybody else that, because I'd be terribly disappointed if she was. But she has gone out of her way over those years, from times where I lived locally and didn't live locally, where I could come by. She would gather information for me, copies of this or that, and just, goes to the extreme of the customer service and personalized service. So she and I also visit about Cannon Beach, which we both like a great deal, but we've never been able to hook up down there. But now she's going to be fully retired, and I did that 3 times ago. So I wish you the best, Connie, and thanks for all of your support, and best of luck in the future.
Yeah, I want to thank Connie. I came in between Tom and Elliot just prior to the 2019, just prior to the pandemic. And Connie was so helpful. I have a unique position in that I participate, but don't vote. And
But you can move in second, and you
I
did
can
that
move a second, I
today.
did that today, yes. So that was really helpful. But one of the things that struck me about Connie is you hear a lot about public employees and public service not working all that hard. I would see emails coming in from her at 8 o'clock at night, 9 o'clock at night, on Saturdays, on Sundays. It was clear that she was getting the job done and getting it done right and on time. And for that, I am really grateful as someone who is new to the organization and really learning all of the ropes. And still after 4 years, it's still a learning process every meeting. So thanks, Connie, for all you've done, and look forward to working with Jessica for the years to come.
Others? Connie? When I first started back at the Healthcare Authority, I left Medicaid and went to corrections for a couple years, not as an inmate, but as a finance manager. So when I came back, it was in February of 12. And to be honest with you, I was not prepared for the difference between Medicaid and commercial insurance. It's significant. And trying to say, well, how is this like Medicaid doesn't work, because it's not like Medicaid, it's very different. And Connie was extremely patient and helped me work through that, whereas a lot of staff understood that I didn't have that technical expertise that had to be learned over time. And Connie was always there for me, and she always supported me, and she always supported the program and this board. I know she had very strong feelings about the board and making sure the materials we sent out, when we sent them out, was all right and perfect. That's resulted in the many late nights and the weekends and all the time that she spent here making sure that was going to happen. Because not only are we trying to organize and control this board, but trying to organize and control staff who are feeding the material into the board, who don't get their material in on time, who don't follow the formatting they're supposed to do, who don't do the, all the things. So, from my perspective, Connie, you were an extremely, extremely vital role in the board. So today, I'm going to turn over the chair to this board to you, and you can close this out. Yeah, you don't have a choice. Or else we just sit here all day. So you have to come and do.
That's your big buddy.
No, actually,
We have an annotated agenda, Connie, just so you know, so you can follow that.
actually,
So-
my nickname from Connie is Pumpkin, which is kind of funny because my cat's name is Pumpkin. So
That's a cat's
Which Connie often says the phrase Lordy Lou, and for years I thought she forgot that her boss changed from Lou to Dave. I didn't realize that was her phrase. I thought she was saying Lordy Lou, and I was like, I'm Dave.
Well, thank you, everybody, for all the kind words. It's very kind. I was going to sneak out in the middle of the night. That was my goal. I've met some wonderful people in this board and this agency. Everyone's so kind and so helpful and so patient with me. I'm the one that sometimes you have to be patient with because I can be pretty stern. But I do appreciate all of your help. So, okay, I'm going to adjourn this meeting. Hot diggity dog. So let's see. Geez, I should have read this. So what time is it? Does it matter?
Well, Connie, you want to see if any board members have any final thoughts or comments?
Oh, okay. Are there any final comments that any board member would like to make?
Finally, shut up.
Kurt raised his hand.
Oh, Kurt?
Yeah, thank you. I just wanted a second to, as my first stint on the board, appreciate not only my fellow board members, but really thank the staff. I've been really impressed with the work that the staff has done and the information and all the time and effort that they spend preparing stuff for the board. So that's just it. Just thank you.
Thank you, Kurt.
Want to thank the
Can I
board
just
for their
say one
service?
more thing?
You can say anything you want.
Now that I'm here, how long do we have? I just want to say that the board is in amazing hands because Jessica and Mackenzie and Maria and all those people that are working on this board that are taking things over, have taken it over this whole season, have done an amazing job. They work circles around me, so you are in very, very capable hands. And I'm so excited for them, and I'm so excited for me to be done. Okay. Yes?
I'd like to make a motion that we adjourn.
Okay.
Oh, you're going to mess with her now.
Okay.
I'll second.
Okay, it's been moved and seconded, we adjourn. Any discussion on that? How am I doing, Mike? Okay, so this meeting is adjourned. Don't make me do that again. You certainly may.
Michael, we didn't have to